Good morning, everyone, and welcome to the Person-Centered Complex Care theme meeting at ARCFEST. I'm really sorry that I can't be with you, but all being well, I'll be out in the sunshine, possibly in the rain, walking in the Brecon Beacons with my family. There's quite a varied agenda that we've prepared for you today, and hopefully it will be a really enjoyable hour and a half. We will have an introduction from Taj Nathan, who's recently joined us as a professional co-lead. There will be some presentations about projects that are in development, following which there'll be an opportunity to discuss and refine them and get a view as to whether we think these are a priority and the kind of projects that need to move forward within our theme. You're going to hear from one of our PhD students and hopefully an internship, and then you'll hear a bit about the household survey work that Jenny and the team have been leading, and then we're going to have some breakouts where there's an opportunity to meet with our public advisors. And if time allows, at the end there'll be some discussion around digital healthcare. So it's quite a packed agenda. Hopefully we can squeeze all this into an hour and 15 minutes, and to make sure there's enough time, I'll stop talking now and wish you all the best for the meeting.
Okay, well, thanks to the pre-recorded Tony. So I'm Taj Nathan. I've recently joined the Person-Centered Complex Care theme as the professional co-lead. So it's a very brief introduction just to say a bit about myself. And I'm going to start by telling you about my current role. So I'm a consultant forensic psychiatrist within Cheshire and Wirral Partnership NHS Trust, which is a provider of mental health and community physical health services. And as well as my clinical roles within the trust, I'm the director of research for the trust. I have honorary academic roles at the University of Liverpool, University of Chester, and Liverpool John Moores University, and also a role within the clinical research network work for the North West Coast as one of the leads for mental health research. So over the years, I've worked across the North West Coast. So my first consultant role was in Merseycare, and I was there for 15 years. And during that time, as well as mostly working in Merseycare, I was also involved in delivering prison-based forensic services in Lancashire. And then over the past 6 years, I've been working for CWP, so predominantly based in Cheshire and Wirral. And although I've always retained a substantive clinical role, ever since I was a trainee psychiatrist in Yorkshire, I've been involved in research. So I thought I was suited to support the ARC and particularly to support engagement because I am particularly passionate about research that is both applied and collaborative. So I'm just going to say briefly what my views are about that. And by applied, I mean that it has direct relevance to people who use and deliver services. So I have a strong feeling that a lot of conventional research undertaken within academic departments that is badged as health research actually has very little immediate relevance to practitioners and users of services. So by saying that, I'm not downplaying the academic importance of that research. And I see it as a lot of it is a sort of basic science, which can help us think about practice. But the point is that it often doesn't directly and immediately inform practice, which is what I'm interested in as a practitioner. And there are all sorts of reasons for that, and there's not time to go into the detail. And I'm happy to get involved in discussions outside the meeting today about any of this. But just to give a couple of examples. So firstly, research questions are often asked by people who don't regularly use or deliver services, and therefore maybe it's possibly too much to expect those academics to understand what may be of direct relevance to clinicians and patients. And another big problem amongst many is that samples chosen by academics who are somewhat disconnected from clinical practice can be so sort of artificial and purified and they don't reflect the real complex sort of messy world of clinical practice, and therefore the findings don't really apply in the real world. Just saying a bit about collaborative. So I said applied, I'm interested in things being applied, as I've said, and collaborative. And my experience, and if I may say to some degree, including of the ARC, has been collaboration or co-production has sometimes been used to describe seeking partner or member approval for academic activities driven by university departments, which sometimes can feel a bit tokenistic. And I believe the balance needs to shift significantly. So it's not just about encouraging engagement from partners and members, it's also about encouraging academics to take risks. And I see that as part of my role, to engage the partners, but also to engage the academics, to take risks and support research that answers questions that are asked by partners and members, even if that isn't what the academics would normally do. So just very quickly to say about what I plan to do in my role. And yeah, I've only been in the role a matter of days, and therefore I need to spend time sort of speaking to people, understanding the current processes and the factors that have led to successful applied and collaborative research. With that sort of caveat, my thoughts at the moment are to have conversations with partners, and I'm available, and I'm happy for people to contact me directly and to get into those conversations. And what I like to do is to identify potential projects that can be used as pilots that would then demonstrate collaboration and the application of research. But for the reason I've already mentioned, the key step is also to have conversations with academics to encourage their engagement with projects that the partners feel are priorities. And I hope that our colleagues will help in persuading academics to engage, two-way process. I suppose the other thing that I'm keen to look at is the bureaucracy involved in developing a collaborative project. And my experience is that it can be overly bureaucratic and off-putting for partners. So I want to explore with ARC and with partners how we can make that less bureaucratic. So that's the end of my talk. It's a bit about me, and I'm looking forward to getting into the discussions in the breakout rooms shortly. So thanks very much.
Thank you very much, Taj. That was very interesting. We're so excited to have you on board. Welcome again. I understand some of you had some technical issues. There were some technical issues, and some of you may have missed Tony's welcome. I do apologize for that. Next, we're going to have 3 projects that have come to the theme. They approached us, and we're looking at working very closely with them. We will be doing some voting as well, so keep your fingers ready to vote. We're going to have a talk by Asan Akpan on virtual MDTs, Alison McCracken on hospital discharges after COVID, and Teresa Sandina on vitreoretinal outcome measures.
Hello, good morning. Thank you for the opportunity to present at the ARCFEST, our project, which is evaluation of a virtual care home multidisciplinary team meeting. My name is Asan Akpan. I'm a community geriatrician and honorary clinical associate professor here in Liverpool. In 2020 in South Sefton, the CCG and the Primary Care Network approached Mercycare and asked us if we could support care homes in a variety of ways, and one of them was to set up a virtual care home multidisciplinary team meeting to provide advice on clinical care for residents about their physical and mental health. In June 2020, this MDT was launched and has been running ever since. This is building already on a well-established good relationship we have with care homes, which we started in 2015 by establishing a network of community matrons and quality improvement activities, which resulted in a reduction in emergency call-outs and hospital attendances and admissions, which we published in one of the geriatric journals. For the present MDT, a referral form is emailed to the coordinator with details of the resident to be discussed. The coordinator then sends this out to all members of the MDT, which come from a variety of backgrounds and include a pharmacist, a dietitian, a social worker, a mental health care practitioner, doctors, psychologists, admin staff, and we usually have trainees from different professional groups and observers. Our initial findings are that some care homes are participating more frequently and readily than others. And within the care homes, we are not quite sure about the process for how the decision is made as to which resident is discussed. The care homes are assumed to have the IT facilities to join in the virtual MDT meetings. We use Microsoft Teams as our platform. In this project, we would be looking to seeing how we can address some inequalities or mitigate them. So we are aware that some care homes are participating more, and we would like to understand any barriers or facilitators that makes this easy or difficult. We would like to make participation as easy as possible for all care homes, and we would like to ensure that all MDT members have equal opportunity in creating care plans for the residents and addressing any issues raised. Throughout the project, we aim to engage with all stakeholders, including commissioners, to discuss any findings that emerge so that we can put this straight back into improving or amending our MDTs. We are presenting here today because we would like to have some academic rigor and support with analytics and an intern to evaluate this model that has now been running for just over a year, and that it will also raise publicity about what we're doing, and importantly allow us to lay the groundwork for future research proposals for this model of care or other models or other recommendations that might emerge. We have a dashboard in place that will be measuring key performance measures, including emergency callouts and admissions. And in the process of this evaluation, it may be that there are other measures that we might have to consider. Throughout this process, we have been using a quality improvement approach to improve the care of what we deliver and for the MDT members to drive any improvements. We hope to increase and improve on any feedback surveys of care home residents and their next of kin, as well as care home staff and MDT members, so that we have a rounded view of the whole process so that any issues are addressed. The benefits of this evaluation will be that commissioners will have a good evidence base to make decisions about funding for these types of care. As providers, we will know which areas are working well and where improvement is required, and it will be a great opportunity to embed research in delivering social and health care to care home residents in collaboration with care home staff and the residents. Thank you for giving me the opportunity to briefly present our project and to seek your support. Please, I'm happy to take any comments or questions, and below are my contact details. Thank you.
So can we move to the voting? Okay, so the first question is, how would you prioritize this outline proposal for ARC? So if you could answer the question. And the next question is, would you or your organization would be interested in participating in this project? Okay, I think, yeah, okay, so we've got 50% that says high and 30% says medium, the rest is low, not priority, and then we've got about 50-50 for would you be interested in this participating in this project. Thank you very much for that. We can end the polling now. Could we go on to our next presentation, please?
Hello, my name's Alison McCracken. I'm an occupational therapist and clinical research therapist at the University Hospitals of Morecambe Bay Foundation Trust. Presentation today is around hospital discharge pathways during COVID-19. As a bit of background, as I'm sure you're aware, the longer term impacts of COVID-19 and the support needs of people who receive hospital level care are still in need of further investigation. Research to date has tended to focus on mortality from COVID-19, although there is beginning to be more research done into long COVID and longer term disability as a result of COVID-19. In March 2020, the government published COVID-19 hospital discharge service requirements with the aim of creating additional bed capacity in response to the pandemic. These guidelines have since been replaced by a similar hospital discharge policy, which was published in August last year. Both of these government policies for COVID-19 discharge pathways are based on the discharge to assess model, which can be seen in Figure 1. According to this model, someone's discharge from hospital can be classified according to one of 4 different pathways. So pathway 0 means that the person returns straight home from hospital and has no additional support needs. Pathway 1 means that someone does go home, but also receives a care package or similar on discharge to support them at home. Pathway 2 means that someone goes to a rehabilitation unit for further rehabilitation. And pathway 3 means that the person is unable to return home after their hospital admission and they instead move into residential care or to a nursing home. The policies published by the government also make assumptions about the proportion of patients who will be discharged on each pathway. So the assumption is that 50% of people will go on pathway 0, which is returning straight home with no additional support. 45% of people will go on pathway 1, so going home with their care package. 4% of people pathway 2 to a rehabilitation unit, and 1% of people pathway 3 to residential care or a nursing home. However, there's very limited evidence to justify the assumptions behind that policy. The aim of this project is to compare the discharge pathways of patients with admission to University Hospitals of Morecambe Bay sites related to COVID-19 with the discharge pathways that were predicted by government documents in both the March 2020 and August 2020 discharge policies, and also to investigate possible associations and health inequalities found within the data. So the methods. This was a retrospective review of the discharge pathways of all patients with COVID-19 who were treated at University Hospitals of Morecambe Bay sites, so that's 3 different hospital sites, from the start of 2020 until the 29th of July 2020. That included a total of 447 patients. So the routinely collected data was extracted and cleaned, and the dataset included items such as date of birth, gender, admission dates and primary diagnosis. And then the case notes for these patients was screened to check what discharge pathway people went on, and that was then coded as either pathway 0, 1, 2 or 3, according to the discharge to assess model we just discussed. So here, this slide shows the provisional findings of what we found. This slide shows the government predictions in terms of what discharge pathway people would go on, which is shown in blue. And then in orange, you can see the actual proportion of patients who were discharged on each pathway in University Hospitals of Morecambe Bay. So we found that 60% of our patients were discharged on pathway 0, so straight home, compared to the prediction of 50%. Pathway 1, we found 22% of people returned home with a care package, compared to the assumption that would be 45%. We found 6% of patients went to 24-hour rehabilitation unit, compared to the prediction of 4%. But also strikingly, we found that 13% of patients were discharged on pathway 3, which means that they were discharged to residential accommodation or nursing home as a new placement, compared to the assumption that that would be 1%. So why is this important? Discharge pathways are likely to be influenced by patients' functional difficulties after COVID-19, as well as the availability of service provision for ongoing rehabilitation and care in the community. So understanding a bit more about discharge pathways gives us some insight into the level of disability after a hospital admission with COVID-19, and it may also help with planning service provision in the future. Just to finish by saying that this work is ongoing and we're still doing further analysis of this data set. And these are links to the 2 different hospital discharge service requirements and policies. Thank you very much for your time.
Okay, so we're going to look at voting for Alison's project now. Can you get the voting up, please? Okay, again, the same questions. How would you prioritize this outline proposal for ARC, high, medium, low, not a priority? And would you or your organization be interested in participating in this project? Please remember to click submit once you have voted. Thank you. Okay, so we're looking at about 76% says hi, and about 39% are interested in this project. Can we share those results, please? There we go. It's gone up a little bit since I last said it. Fantastic. Can we please go on to the next presentation? Thank you.
Good morning, everyone, and thank you very much again for the opportunity to talk about our project. My name is Teresa Sandinha. I'm a consultant and one of the vitreoretina surgeons at St. Paul's Eye Unit in Liverpool. Our project is about PROMs, or patient-related outcome measures in vitreoretina surgery. And why do we think this is an important topic for this forum? Well, vision is our most important sense that we do not appreciate enough until we lose it. Visual loss can be caused by several diseases that affect the retina and need to be treated by surgery, such as retina detachment, macular scarring, macular holes, and complications from diabetic eye disease, such as bleeds. And in addition, visual impairment in older people leads to poorer quality of life, increasing the risks of falls and mental health problems such as depression. So traditionally, we obsess about how many letters patients can read in the chart, but what's the point in doing this if, for example, even though our patients can read the chart, they are distressed and disabled by post-operative problems such as double vision. And in fact, some patients will say they wish they had never had the operation. So it is still apparent the disconnect between how ophthalmologists perceive success after surgery compared to how the patients really feel. And in a recent webinar last week on the 23rd of June with a PPI group of patients suffering with macular edema due to diabetic eye disease, these are some of the comments they made. So one patient said, "Straight lines look wavy and blurry. It feels very scary and I'm frightened I will lose sight in both eyes." Another young lady said, "It makes me worry what my future will look like. I also would love children and I worry about the impact these would have on my eyes." So mental health is key and it needs to be factored in when considering managing and treating these patients. Here in Liverpool, we have already shown that after macular hole repair surgery, mental health and not vision was the factor that patient reported was most improved when we assessed visual function, quality of life after surgery. And as a consultant of 10 years experience, I was honestly surprised by this. So we need to move away from the sole use of traditional outcome metrics, such as vision, anatomical features of the retina, or how the retina looks on scans, towards inclusion of metrics that matter as much or possibly more to patients and providers, such as quality of life, convenience, and cost of treatment. We need better decision-made tools to really ensure every patient released for surgery has the best chance possible of having a better quality of life and not just more letters on the chart. And I would like to stress that so far there are no specific vitreoretinal problems that we know of, and no core specific outcome sets in these patients requiring surgery for retina conditions, and we aim to develop the first one. And having developed the specific problems, we want to validate on our patients to assess whether we can improve their experience outcome from surgery. The plan involves completing a systematic review on problems for VR surgery and qualitative research with focus groups to reach consensus as what is relevant for these patients. By supporting us with the PROMS project, we believe we are all working towards a more patient-centered care approach, which will lead to better outcomes for these patients and will help reduce health inequalities. The data we will gather will also help future applications to develop a portfolio study funded by the NIHR to build capacity and capability through regional and national networks. So finally, I would like to thank you, all my colleagues who've been helpful in the discussion of this project, including Thomas Sharp, a senior optometrist at St. Paul's, who is keen to do an internship to take this further project. Further. Sorry. Many thanks.
Final voting for this session. Can we please have the voting up? Please vote now. Same questions. Okay, can you please share the voting results? So it's fairly equal for the high and medium prioritization. And looking at, if you'd be interested, about 28% would be interested. That's great. We would look at identifying who is interested in participating in the projects we've just shown, and we will look at linking you up with the PIs of the projects. Thank you. Can we stop sharing results, and can we move on to the next presentations, which are a presentation by one of the PhD students. Then we have another presentation by an internship, and then we have a presentation on the HHS work. Can play now.
Hi, I'm Sean Gallagher. My person-centered complex care themed research project is titled Self-Management Intervention for the Treatment of Diplopia in Ocular Cranial Nerve Palsy. So a bit about my background. After graduating from the University of Sheffield with a degree in orthoptics in 2016, I've worked as an orthoptist in multiple hospitals across the country. In Brighton and Sussex University hospitals, I worked as a research orthoptist, facilitating the retinal and anterior segment specialists' studies. So, with my research project, the aim is to develop a new active self-management intervention for ocular cranial nerve palsy, which will most likely be a form of eye exercise. The project is of mixed methods design and comes in 3 phases. Phase 1 is a systematic review of current non-invasive treatments of ocular cranial nerve palsy and neurological gaze disorders, and I'm currently halfway through this. Phase 2 is to conduct focus groups or interviews with patients who have suffered from double vision within the past 12 months and with orthoptists who have been in practice for at least 1 year. And this is so that we can find out from the patients what they believe will be helpful to facilitate them being able to do a potential future treatment, and also find out from orthoptists what will be helpful for them to know in order to give this treatment to patients in future as well. And ethics has been submitted for this. And the last phase will be a feasibility study using the newly designed self-management intervention. This research has potential benefits both in regards to person-centered complex care and in regards to reducing health inequalities. Ocular cranial nerve palsies quite often occur due to stroke or other neurological conditions, meaning that patients often have other comorbidities. So through a faster recovery from double vision, we can allow patients to focus on their recovery from these comorbidities. Ocular cranial nerve palsy is also more likely to occur in those of lower socioeconomic status, who will find it more difficult to access treatment for the double vision, alongside patients with poor mobility. By introducing a self-management intervention, we can actually reduce the number of review appointments that are necessary. And if the treatment does speed up the recovery from double vision, it then reduces the impact of the condition on a patient's quality of life and their finances. The benefit of working with the applied research collaboration means that I'm part of a scientific community that is focused on conducting research, which has the ability for its findings to be put straight into a clinical setting, which means that patients are able to benefit from this research directly. And thank you very much for listening.
Hello everybody, my name is Jane Nerney and I am Informatics Clinical Change Lead at Merseycare NHS Foundation Trust. Currently also I'm doing an ARC internship. The question that I want to address is, what is the best way to implement electronic news 2 in the community? Firstly, I want to tell you a little bit about myself. I'm qualified as a physiotherapist, and for most of my time working as a physiotherapist I specialised in paediatric therapy. Always had a great love for children, and I've also then went on to work as an operational manager across universal child health with health visitors and school nurses, and this further widened my knowledge of child health within the NHS. After that I moved on to informatics to work as part of the RIO project implementation, RIO being an electronic patient record, working across mental health and community services. This really increased my knowledge of mental health services particularly, and different other community services. Now I'm Informatics Clinical Change Lead, and I feel that I'm in the post to enhance the system, RIO, improve the clinical quality, clinical data quality and patient safety. So News 2. What's News 2? News 2 is a system to standardise the assessment and response to acute illness, and this was developed by the Royal College of Physicians. This measure takes 6 physiological parameters which are routinely recorded and calculate a News 2 score. The 6 parameters are respiration, oxygen saturation, systolic blood pressure, pulse, level of consciousness and temperature. Now in April 2018 NHS England issued a patient safety alert for adoption of News 2 in acute and ambulance trusts by 31st March 2019. So in North West Boroughs Foundation Trust, where I was working at that time, we introduced an electronic version as an integral part of RIO, just for the inpatient setting. This involved form development, rigorous testing, training and contributing to the procedure development. Moving on to introducing News 2 in the community. The Royal College of Physicians' final report about News 2 recommended that this should be used in the pre-hospital assessment of acutely ill patients. So for example, by Northwest Ambulance, by ambulance services as well as community services. News 2 in the community is not currently widely used. Okay, so what we did was we took the inpatient electronic News 2 template and we amended it to suit the community service and setting. We didn't change, well, we can't change any of those 6 parameters and the score that I mentioned, but obviously we had to change the escalation process for a community patient, because of course that would be different for an inpatient than for an inpatient. We started this implementation as a staged approach in November 2020, but there was some delay due to COVID pressures, and initially we implemented it with a community matron team. So about my ARC internship. I started this in January this year, and as I mentioned before, I want to look at how best to implement the electronic News 2 solution across varied community teams for optimum assessment of acute illness, detection of clinical deterioration and a timely response. So the teams that we have in our community services are community matrons, district nursing, frailty and treatment rooms, and all of those teams have a different experience of News 2, so we require a bespoke implementation plan for that reason. And some of the clinicians it wasn't even introduced that they use it on paper or using it at all, so obviously there's quite a variation. So to support this project, I'm completing a module at UCLAN, improving clinical care through implementation science. So thank you for listening to me. I'd really welcome any contact if you're just interested in finding out about the project, or if anybody has any experience of implementation of News 2, either paper or electronic. I'd really welcome a conversation, and feel free to contact me on the email address above. Thank you.
Hi everyone, today I'm going to talk about digital readiness prior to COVID-19 and consider the implications for health equity. I'll discuss this in the context of the analysis and findings from Wave 2 of our North West Coast Household Health Survey. Just to provide a bit of background on this topic, Office of National Statistics data provided pre-COVID levels of internet access in 2020 and showed that around 4% of households did not have access to the internet, which was a decrease from the 2018 data, which showed that the figure was 10%. Although more people are accessing the internet, there are still over 11 million people nationally who lack basic digital skills. We know that the elderly and disabled groups are less likely to have the internet or to use it much even when they do have it. But those defined as financially vulnerable, such as people with mental health conditions, are also less likely to have access. Although we don't know the impact of COVID-19 on levels of new internet users, we do know that frequency of internet use has increased dramatically in the past year or so, and that pre-COVID smartphone use was increasing in those over the age of 75. However, this increase came with a decrease in landline ownership, which raises issues around possible cost implications for people, particularly those with pay-as-you-go or limited data contracts. Access to health and social care is increasingly online. Some services and forms are almost exclusively online. And now, due to primarily to COVID, there's a digital-first approach to healthcare appointments which dominates, and that also has the potential to increase health inequalities. We know that COVID-19 has been a catalyst to speed up the adoption and spread of technology during lockdown. It's been used for essentials such as communication and food deliveries, and to support homework and homeschooling, and most importantly to maintain healthcare provision. But the implications for those with limited access to technology and internet or the skills to use technology is unknown, as is the scale of the disparity. The Household Health Survey provides us with insight into internet access for a largely deprived subset of the North West Coast population prior to COVID lockdown. The research questions posed for this analysis were: who has access to the internet? What socio-demographic factors are associated with no internet access? And is health status and health and social care use associated with having no internet access? So what did we do? We used the second wave of Household Health Survey data, which was collected in 2018, and we developed a variable to examine personal internet access versus no personal internet access. We used socio-demographic measures to examine internet access by age, sex, indices of multiple deprivation, housing and work status. We also included health conditions and healthcare use, and conducted both univariate and multivariate analysis. This chart shows the total responses from the Household Health Survey when people were asked what their main method of accessing the internet were. Clearly, the vast majority use a mobile or home device, but others responded that work, family, or publicly accessible Wi-Fi was their main method of accessing the internet, whilst others stated that they had no access or were unable to use the internet. We took these responses and categorised them as personal internet access, which indicated access at home, or no personal access. Overall, almost 22% of respondents had no personal internet access. Univariate test shows that there was no difference in the type of internet access between males and females, between those accessing the pharmacy or not, or between those scoring as moderately depressed or not. However, there were a number of significant differences in personal internet access reported by socio-demographic factors, for example, age, ethnicity and level of education, to name a few, and also by number of health conditions and levels of health and social care use. We conducted a logistic regression to examine factors associated with no personal internet access. In the final model, A&E use, walk-in clinic use and housing were removed to improve the fit. Sex, ethnicity, primary care use and pharmacist consultation use were all non-significant. This graph shows the remaining significant associations from the model. The orange dots are the odds ratios, which are labelled, and the lines show the confidence intervals. Overall findings show that age was the greatest factor for reporting no personal internet access. A person aged 65 or older is over 20 times more likely to report having no personal internet access than someone aged 18 to 34 years. Low education was the greatest social determinant. Someone with no qualifications was 4.4 times more likely to have no personal internet access than someone with a university degree. Deprivation, multiple health conditions, and social service use were all also significantly associated with no personal internet use. Being employed and having outpatient appointments in the past year was significantly associated with decreased odds of no personal internet access. In summary, almost 22% of those surveyed in 2018 did not have personal internet access. This is a much larger proportion than the 10% reported in 2018 nationally, which may be due to the fact that the Household Health Survey was carried out on a largely deprived population. And this may be a good indicator of the scale of the problem in the North West Coast. Also, the face-to-face method of data collection used in the Household Health Survey may mean that it's more likely to capture data relating to the digital divide compared to many other surveys, particularly those conducted online. Findings showed that those working and those less deprived were more likely to report having personal internet access. Potentially, this indicates that the financial cost of the internet and devices influences access. We need to consider post-COVID that this disparity may be more pronounced. Older populations were much less likely to have personal internet access. This is an unsurprising finding. We know older people may lack skills, dexterity, or have another disability that prevents access, and personal choice may also play a part. But even adjusting for age, we found that those with low educational attainment were less likely to have personal internet access, which highlights that those in low-paid, manual, temporary, or unskilled jobs may be particularly disadvantaged through the cost of the internet, devices, and an inability to access digital skills training. This also highlights the importance of ensuring that people in education and training currently are given appropriate digital skills training. So what are the COVID implications? People without personal internet access may have had greater difficulty accessing information about COVID symptoms and the ever-changing lockdown rules. Also, information about COVID tests, test sites and booking a COVID test was predominantly online, so this could have been a major barrier for some. Evidence from the pilot Liverpool lateral flow test evaluation and subsequent publication by Mark Green and colleagues from the University of Liverpool did find that in those populations reporting less confidence in using the internet, fewer tests were carried out. Since the start of COVID, access to healthcare was predominantly remote through the internet and phones. Emergent evidence indicates a lack of patient satisfaction with remote consultations during COVID. This is particularly among the elderly, those with carers, those with learning difficulties, and the unemployed. Also, populations without internet access may have experienced more isolation, suffering from the inability to shop online for food and other essentials. They may have struggled to access appropriate health and social care, particularly if they were shielding, thus potentially impacting mental and physical health long term. So what are the future possibilities for reducing health inequalities? Virtual wards and multidisciplinary teams may provide a more efficient, personalised and timely service, but there's limited evidence to suggest that everyone who wants to engage with services remotely can do so. A digital-first approach post-COVID needs to be personalised, evidence-based and driven by patient choice, and further evaluations of remote care are needed. More effective solutions also need to be produced with marginalised and excluded groups. And what are the policy implications? Post-COVID, more people may be financially vulnerable. It's also possible that internet-based routes to health and social care services may create or indeed increase financial burden, especially for those accessing on mobile devices who may have pay-as-you-go or limited data contracts. Solutions could be found through the extension of free public Wi-Fi, and access to appropriate technology is very important. During COVID lockdown, there was free data and some free devices provided to families who were homeschooling, and more initiatives like this are needed. However, access to technology and internet at home, although important, is not everything. There's also a need for accessible hands-on support for people to be able to get help to access, for example, social services online. One good example of this has just been announced for Liverpool with a new one-stop shop model called Customer Hubs, based in local libraries, providing direct support in the community. To conclude, COVID-19 has been a catalyst for change and innovation, and we don't know yet how this has shaped current health and social care access and use, and the health inequalities implications of this long term. It's important for future recovery that we gain a greater understanding of the impact COVID-19 and lockdown have had on the digital divide and the long-term health of the population. It's important that we move forward ensuring that consideration of health inequalities is kept at the forefront of digital innovations in healthcare and health and social care delivery. Thank you.
Okay, thank you very much to all our speakers. I hope you've got an idea of what sort of projects come within the PCCC theme. Without further ado, I'm going to move into the next session, and that is a breakout session. Here you can be split into two groups where you'll have an opportunity to speak to both our public advisor co-leads and our member co-lead as well. After about 10 to 12 minutes, you'll be the facilitators or the public advisors and the member will swap rooms, so everyone gets an opportunity to speak to both the public advisor and member co-lead. Can you please move us into the breakout rooms now? Okay, I do apologize everyone for the technical issues that we've had today. Something that you kind of expect, isn't it, nowadays? But we did have our fingers crossed, I do promise you that. Just quickly wrap up, I know we're into our break now. Jenny, do you want to quickly take over? I'll just quickly share my screen.
Yeah, sorry that we're just going to have to make this really rushed, but we just wanted to, we're quite excited to say that we're launching a digital healthcare research development network. we wanted to, oh, you have got slides, great. So as you know, that we've got our digital healthcare sub-theme in the person-centered complex care theme, and we know that this is a really topical issue at the moment. We felt that this was a really good time to launch a network to bring our staff across the ARC and all of our ARC members together. If you could just move to the next slide, have I got access to this? We're going to have our first meeting on the 14th of July, and we want everybody's help to be able to shape that meeting and to shape the network moving forward. So what we've got is a Jamboard link. If people could add their views about the aims of the network, the objectives or the outcomes of the network, and the member priority areas that we can help to use to shape the agenda for our first meeting, we'd really appreciate that. The link is in the chat. It'll be open for a good couple of weeks, and Pallavi and I will keep a check on that. So please feel free to add comments, give examples, to add your views. You can do it anonymously, or you can do it with, you can put your name and your organization down, and we'll take that on board and help that to shape our network moving forward and to shape the first meeting that we've got. The invitations will go out tomorrow. If you don't receive that, please do email us, email myself or email Pallavi, and we will make sure that you receive an invitation for that meeting and future meetings as well. If you do receive the invitation and you can't come, please feel free to give that to a colleague to represent your organisation at the meeting. And I think really, that's the main thing. That's the main thing that we want to say. But please have a look at the Jamboard. See if, even if you just answer one of the questions, have a look and see what you can contribute to that. And I guess really we just want to thank people for attending the session. Apologies for the technical issues, and hope that you enjoyed the rest of the day. And also, we certainly hope that we get to see people face to face at our next session. It will be a hybrid session, and we know that not everybody will be there face to face, but we certainly hope that we get to see some people face to face in September. Thanks very much for joining our theme meeting today.
Thank you, everyone. Bye.
Thanks, everybody. Thanks.
Bye then.